If you've ever stared down a confusing medical bill, or maybe you've sat in a sterile clinic room while a doctor sketched out a surgical plan for a loved one, you know that medical jargon can feel like a totally impenetrable foreign language.
Oh, absolutely. It's like they're speaking in code.
Right. But while I was combing through this huge stack of medical history texts and etymology sources recently, I realized there is one specific suffix that acts like a universal decoder ring. So today, our mission in this deep dive is to decode that exact string of letters. We're looking at the suffix plasty.
Yeah, which is a big one.
It's huge.
Yeah.
We're going to explore exactly how surgical reconstructive procedures get their names and trace this really fascinating timeline that spans all the way from ancient India to, like, modern high-tech catheterization labs. So if you want to understand the secret language of surgical repair, you are in the right place.
Because once you grasp the mechanics of this one suffix, you instantly understand the fundamental logic of what a surgeon is trying to achieve in the operating room. At its most basic textbook level, plasty means the surgical repair, reconstruction, or reshaping of a body part.
Just reshaping.
Exactly. So taking the combining form for nose, which is rhino, and attaching plasty gives you rhinoplasty, which is just the surgical reshaping of the nose.
On paper, I mean, it sounds incredibly straightforward, but we need to immediately shatter the biggest, most common misconception people have about this word because it completely warps how we think about these procedures.
Oh, the plastic thing.
Yes. When people hear a phrase like plastic surgery or a term ending in kiloplasty, the immediate assumption is that it has something to do with the physical material, plastic.
Right. They picture artificial synthetic polymers being implanted into the human body, which makes intuitive sense given how ubiquitous synthetic plastic is in modern medical devices, from IV bags to joint components.
Totally.
Etymologically, though, that assumption is completely backward.
It is.
The surgical suffix traces its roots to the ancient Greek verb plastein, which means to mold or to form, and its associated adjective plastikos, which translates to fit for molding.
So the surgical suffix is actually older than the synthetic material. I mean, Bakelite, which is recognized as the first fully synthetic plastic, wasn't even invented until 1907.
Right.
But surgeons were already writing extensively about plastic procedures nearly a century before that. It is exactly like a modern tech company appropriating an older dictionary word for its product.
Oh, that's a good way to put it.
Imagine a massive tech conglomerate naming itself Cloud Data, and then a century later, a new generation assuming the fluffy white things in the sky were named after server farms.
Yeah, that's exactly what happened. The synthetic material borrowed the name from the surgeons because it, too, could be molded and shaped.
And the surgeons definitely laid claim to the word first.
They did. The person most credited with officially fusing this Greek root onto our modern surgical nomenclature is a German surgeon named Karl Ferdinand von Greffe. So in 1818, he published a foundational medical text titled Rhinoplastic. He was actively cataloging techniques for rebuilding noses that had been lost to syphilis, severe facial trauma, and this is wild sword dueling injuries.
Oh, wow. Just the phrase dueling injuries paints such a vivid picture of the era. He was essentially writing a manual for putting faces back together.
Exactly, because sword dueling was a massive disfiguring problem among the aristocracy and military classes in early 19th century Europe. So his book is widely considered the moment where plastic and its eventual English descendant plasty became a formalized suffix in surgical vocabulary.
It graduated from a simple descriptive word to a real medical category.
Right. And then 2 decades later, in 1838, another German surgeon named Edward Zeiss published a comprehensive handbook that cemented the broader term plastic surgery for the entire emerging discipline of tissue reconstruction.
Okay, but here's where it gets really interesting. Von Grace might have popularized the German term in 1818, but he was absolutely not inventing the underlying surgical technique.
No, not at all. He was just slapping a 19th century European label on something profoundly ancient. The exact, highly complex technique he was describing for rebuilding a nose, using a specific flap of skin harvested from the patient's own forehead that is detailed in the Sushruta Samhita, which is a foundational ancient Sanskrit surgical text from India compiled around 600 BCE.
The mechanics of how that ancient procedure worked are just astonishing when you consider the complete lack of modern anesthesia or antibiotics.
Right, they had none of that.
None. In ancient India, the amputation of the nose was a standardized punishment for crimes like theft or adultery, and obviously it was a frequent casualty of warfare.
Yeah.
So Shrupa documented a highly specific method of taking a leaf-shaped flap of skin from the forehead to rebuild that missing nasal structure.
The critical engineering genius here was that he left the flap partially attached at the base, right? Right between the eyebrows.
Yes.
Wait, they were performing complex rotational skin flap reconstructive surgery 2,600 years ago, and we are still using the exact same design today. We are still teaching it to surgical residents right now. Leaving that skin attached at the base creates what modern surgeons call a pedicled flap.
A pedicled flap.
Yeah. By leaving the base intact, you preserve the blood supply coming from the supratrochlear artery.
Oh, okay.
Think of it like moving a plant to a different part of the garden without cutting its main root. If you just slice a piece of skin completely off a forehead in 600 BCE and sew it onto a nose, it dies.
Right, the tissue turns necrotic and falls off.
Exactly. But by simply rotating the tissue down over the nose while keeping that vital blood vessel intact, the tissue stays alive and nourished while it heals into its new position.
That is just brilliant biological engineering.
It really is. And British surgeons actually rediscovered this exact method much later in 1794. They witnessed it being performed successfully on a bullock cart driver in India who'd suffered a nasal amputation.
Wow.
A detailed account of that operation was published in a London magazine, and that direct observation flowed directly into the European surgical tradition that von Greif later named.
So the word is 19th century German, but the biomedical engineering is ancient Indian.
Precisely.
We have this foundational idea of plasty as a very physical scalpel and suture cut and paste reconstruction. But as we move from ancient texts into modern medicine, the boundaries of that definition get incredibly fuzzy.
Yeah, they do. The working definition used by modern surgeons, medical board credentialers, and insurance coders has expanded significantly. Today, a plasty is broadly defined as any operative or interventional procedure that changes the form or structure of tissue to restore, improve, or alter function or appearance.
Which is a very expansive definition.
Very. And it creates three major conceptual tensions in how the medical field applies the word today.
Okay, so the first tension revolves around the physical mechanics, right? Does a plasty require adding new material, or does it just mean reorganizing what is already there?
Right.
Because we just talked about rhinoplasty, which often involves taking cartilage grafts from the ear or the rib and adding them to the nose to build up its structure. You are physically adding building blocks.
Right.
But contrast that with a gastroplasty, which is a common procedure used for weight loss. The surgeon isn't adding any new tissue or synthetic material to the stomach. They're simply folding and stapling the patient's existing stomach tissue to structurally reorganize it into a smaller pouch.
So the suffix covers both adding material and merely rearranging it.
Exactly.
And then the second tension shifts from the physical mechanics to the philosophical goal of the surgery. Does arthroplasty mean restoring a body part to its original historical function, or does it include building an entirely new structure that never existed in that specific form?
That's a huge shift.
It is. Historically, if a surgeon performed a reconstructive rhinoplasty after removing a cancerous tumor, the explicit goal was to restore the nose to its prior baseline state. The blueprint was the patient's past anatomy.
Right.
Today, however, the suffix is heavily utilized in gender-affirming surgeries, such as vaginoplasty and phalloplasty. In these complex reconstructive procedures, the surgical goal is to construct new anatomical structures that align with the patient's gender identity.
Which represents a major conceptual shift in the architectural meaning of the word.
Yeah.
I mean, it's no longer strictly tethered to restoring a prior anatomical state, but has expanded to include building a new sodas to achieve a targeted structural and functional outcome.
Exactly.
Okay, let's unpack this. Because the third tension is where my brain really struggles with the traditional definition. This is the tension between open surgery and closed interventions.
Oh, yeah.
For the vast majority of medical history, a pharoplasty meant a scalpel, a large open incision, a lot of bleeding, and a surgeon's hands physically inside the body cavity. But today, one of the most frequently performed pteroplasty procedures on the planet is an angioplasty.
Which is the mechanical widening of a narrowed or obstructed blood vessel.
But look at how it's actually done. In modern angioplasty, a cardiologist makes a tiny needle puncture in your wrist or your groin. They thread a thin wire and a catheter all the way through your vascular system up to your heart. There is no scalpel. There's no incision anywhere near the actual site of the repair. How can a procedure managed through a tiny plastic tube from 3 feet away even be classified alongside open, scalpel-based reconstructive surgery?
It's a great question, and it forces us to ask how we define surgery in the 21st century. To understand how a minimally invasive catheter procedure hijacked a heavy-duty surgical suffix, we have to look at the historical milestones that redefine what the human body could endure.
Okay.
Let's establish the baseline with a classic, highly invasive open surgery milestone: total hip arthroplasty. In 1962, a British orthopedic surgeon named Sir John Charnley introduced a radical new approach he called low-friction arthroplasty.
And the attempts to replace joints before Charnley were pretty horrific mechanically. I read that surgeons in the 1890s were trying to use carved ivory prostheses,
Yes.
and by the 1920s they were testing hollow blast molds.
Which is terrifying because the mechanics of the human hip joint are brutal. It bears massive weight and requires constant smooth articulation. Ivory degraded and glass shattered under the immense physical stress.
It's all
So Charnley completely changed the paradigm by looking at modern engineering materials. He used a small stainless steel femoral head, paired it with a socket made of high-density polyethylene plastic,
okay.
and crucially, he figured out how to lock those components permanently into the human skeleton using acrylic bone cement.
Wow.
The mechanics were so frictionless and the durability was so transformative for patients paralyzed by arthritis that the Lancet later dubbed total hip replacement the operation of the century.
And that procedure firmly cemented paramedicalplasty in the public imagination as this highly invasive, structurally permanent architectural fix involving heavy tools and artificial parts.
Exactly. But the ink was barely dry on that definition when Charles Dotter came along just 2 years later in 1964 and completely flipped the script.
Right.
Dotter was an American radiologist, not a traditional surgeon. He was consulted on an 82-year-old patient named Laura Shaw. She had a completely gangrenous foot because the major artery supplying blood to her leg was entirely blocked by plaque.
And the standard surgical protocol was a leg amputation.
Yeah, which she absolutely refused. So Dotter took a radical approach. He used a technique involving coaxial catheters.
Let's explain how coaxial catheters actually work for anyone who isn't a medical engineer, because this is fascinating. Imagine sliding a tiny, thin coffee stir straw over a guide wire into the blocked artery.
Okay.
Then you slide a slightly larger standard drinking straw over the coffee stir. Then you slide an even wider boba tea straw over that one. By forcing progressively larger tubes over each other through the blockage, you mechanically push the plaque outward and stretch the walls of the blood vessel open from the inside.
And that physical dilation restored the blood flow to Laura Shaw's leg without a single surgical incision near the blockage.
Incredible.
The gangrene halted, the pain vanished, and reports confirm she walked out of the hospital on that leg.
She walked out.
Yeah. Dotter essentially birthed the mechanical concept of angioplasty. Then, in 1977, a physician named Andreas Grünzig took Dotter's concept a massive step further. He performed the first balloon angioplasty in the coronary arteries of a conscious patient in Zurich.
A balloon.
Yeah, instead of just sliding stiff tubes over each other, Grünzig developed a catheter with a tiny balloon at the tip that could be inflated with massive pressure once it was inside the blockage, crushing the plaque against the artery walls.
Wow.
And the wild detail from the historical sources is that Grünzig reportedly built the early prototypes for those delicate balloon catheters at the kitchen table in his own apartment.
Just incredible ingenuity.
Yeah.
But going back to the tension between open and closed surgery, Grünzig's success didn't just launch the modern era of cardiac catheterization labs. It launched an absolute turf war in the medical field.
Oh, it was huge.
Traditional scalpel-wielding surgeons were suddenly staring down these interventional cardiologists and radiologists and saying, wait a minute, you aren't scrubbing in with a scalpel. You aren't opening the patient's chest cavity. Can we really allow you to count this as a plasty?
Right. They fought bitterly over how these new catheter procedures should be classified for hospital credentialing, for residency training, and especially for insurance billing. The traditionalists felt that applying a surgical suffix to a needle puncture degraded the definition of surgery.
I completely understand the traditional surgeon's frustration, though.
Yeah.
Imagine a group of old-school auto mechanics getting into a fist fight with the new generation of technicians over whether fixing a car's engine from the inside by snaking a robotic tool all the way up through the exhaust pipe actually counts as opening the hood.
Yeah, the exhaust pipe analogy perfectly captures the debate. Ultimately, the functional outcome won the argument. The broader medical community agreed that the suffix plasty names the result. the successful repair, reconstruction, or reshaping of the tissue, not the specific tool used to achieve it.
So whether you use a bone saw or a kitchen table balloon catheter, if you structurally reshape the anatomy, it earns the suffix. Rebuilding the human body isn't always a flawless success story, though. We have talked about these incredible medical milestones, but plasty has a very dark side when the engineering simply fails.
It definitely does.
We hear words like arthroplasty or gastroplasty, and they give off this comforting illusion of permanence. We think of them as permanent architectural fixes to our bodies. But the reality is that many of these procedures are essentially engineering prototypes being tested inside the human body under immense, unrelenting physical stress.
That's a really important point. The interior of the human body is an incredibly harsh, corrosive, and dynamic environment. A striking example of anatomical engineering failing over time is vertical banded gastroplasty, which most people know as stomach stapling. This was developed by surgeon Edward Mason in the 1980s.
This was the absolute dominant weight loss surgery in the United States for an entire decade.
It was, and the biomechanical concept looked incredibly elegant on paper. The surgeon uses staples and a synthetic band to partition the stomach into a very small upper pouch, restricting how much food the patient can eat without having to surgically reroute the intestines.
Right.
But when researchers looked at the long-term outcomes data in the 1990s and 2000s, it revealed a biomechanical nightmare. The staples would physically break down under the relentless hydraulic pressure of daily digestion. The stomas, which are the small surgical openings created to let food pass, would stretch out.
Think about it like this. If you take a rubber band and stretch it to its maximum tension every single day for 5 years, eventually it loses its elasticity and just stays permanently stretched out. That is exactly what was happening to the patient's stomach tissue.
Exactly. The mechanical restriction failed, patients regained the weight, and the procedure was largely abandoned for more durable structural methods like the gastric bypass.
Wow.
And sometimes the failure isn't just about the procedure losing its mechanical effectiveness, it is about the materials themselves becoming actively toxic to the patient.
Like the hip replacements.
Yes, the metal-on-metal hip arthroplasty crisis is a prime example. In 2010, the medical device company Johnson & Johnson had to execute a global recall of their DePuy ASR hip system. Registry data, specifically rigorous tracking from the UK, showed that the failure and reoperation rates were unacceptably high.
Why?
The problem was entirely mechanical friction. When the heavy metal ball rubbed against the metal socket with every step the patient took, the friction shed microscopic cobalt and chromium ions directly into the surrounding joint tissue and bloodstream.
And the body's immune system reacted to those heavy metal ions as foreign invaders, right?
Yeah.
Causing massive local tissue damage and creating what surgeons called pseudotumors around the joint.
Yeah, it was awful. It escalated into one of the largest orthopedic recalls in modern medical history, and it completely reshaped how global regulatory bodies evaluate the long-term friction and wear safety of joint implants.
Unbelievable.
And while we are discussing the intersection of public safety and regulation, we have to look at mammoplasty, specifically regarding silicone breast implants.
Oh, right. Think about the massive breast implant crisis in 1992. The public panic regarding ruptured silicone gel implants and a suspected link to systemic autoimmune diseases was so intense that it actually helped push the massive manufacturer, Dow Corning, into bankruptcy.
Wow.
The FDA had to step in and heavily restrict their use pending a massive safety review.
Right, and the public outcry was deafening, but the subsequent scientific data told a very different story. Massive, multi-year epidemiological studies consistently failed to establish a clear causal link between the silicone implants and systemic autoimmune diseases.
This is just panic.
Largely. Relying on that data, the FDA lifted most of the severe restrictions in 2006. It remains a fascinating historical case where public fear vastly outran the clinical evidence. However, the underlying risk of the materials mechanically failing, the implants rupturing over time due to wear and tear and requiring a complex reoperation, were and still are very real engineering risks that surgeons are ethically obligated to disclose to patients today.
We have journeyed through the ancient surgical triumphs, the modern catheter revolutions, and the sobering engineering failures. Now let's zoom out and make this actionable.
Let's do it.
I want to give you, the listener, the practical tools to decode any medical chart, billing statement, or surgical plan you might ever encounter, because the lost plasty does not exist in a vacuum. It sits inside an entire family of surgical suffixes. If you learn how the secret code works, you immediately know a surgeon's entire strategy just by looking at the last few letters of the word.
It is genuinely the fastest way to become fluent in medical terminology. So, if plasty means to rebuild or reshape, think about the opposite instinct. If a surgeon's goal is to remove something entirely, the word will end in nephrectomy, like an appendectomy.
Right. You are not rebuilding the appendix. You are cutting it out and throwing it away.
Exactly. Now, if the surgeon just needs to look inside or access something, they use ileotomy with an O, like a tracheotomy.
So that just means to make a physical incision or cut into something. You aren't removing it. You aren't reshaping it. You're just opening a door.
Yes. And often, anatomy is the very first step before a surgeon can perform an anatomy or an plasty.
Makes sense.
If the surgical plan requires leaving that door permanently open for drainage or waste, they create an ostomy, like a colostomy surgically, creating a new, permanent opening to the body surface. If they find an internal structure is loose and needs to be physically anchored to a wall, they use mehoxy, meaning surgical fixation, like an orchiopexy.
And if they're just stitching tissue together to repair a tear, they use mycography, meaning surgical suturing, as in a herniorrhaphy for a hernia repair.
Exactly.
If the goal is to violently crush something, like using sound waves to obliterate a kidney stone, that is the mycrypsy, specifically lithotripsy. And if they just want to look around inside a joint using a fiber optic camera, that is a mycoscopy, like an arthroscopy.
Perfect. But we have to warn everyone about the biggest, most dangerous potential mix-up in this entire nomenclature system.
Oh, this is crucial.
The critical difference between arthroplasty and arthrodesis. They sound incredibly similar. They target the exact same anatomical joints, but they represent functional absolute opposites.
Yeah, the suffix desis means surgical binding or fusion. So in arthroplasty, the quilplasty is designed to reconstruct the joint with metal or plastic, specifically to preserve or restore the patient's physical motion.
Right.
But arthrodesis is designed to deliberately and permanently eliminate motion in that joint by fusing the bones together, usually as a last resort to stop severe intractable pain. Confusing those two letters on a surgical chart means the difference between a patient keeping their ability to walk normally or having their skeletal bones permanently locked together.
A truly high-stakes typo. But once you understand these suffixes, you compare them with a rapid-fire list of combining forms to decode almost anything in the human body. Blepharo is eyelid, so blepharoplasty is reshaping the eyelid. Gastro is stomach. Chondro is cartilage. Osteo is bone. Cranio is the skull.
So what does this all mean for you? It means you are no longer at the mercy of intimidating polysyllabic medical jargon. If a doctor sits down and says you need an arthroscopy followed by a chondroplasty, you know instantly. They are going to use a camera to look inside your joint, and then they're going to surgically reshape your cartilage. You possess the decoder ring.
And possessing that decoder ring matters more today than at any point in medical history because the real-world footprint of the plasty suffix is massive and growing. Total joint arthroplasties are serving an aging global population that refuses to surrender their mobility. It is a central pillar of modern public health.
Absolutely.
Angioplasty is the literal life-or-death frontline treatment if you are rushed to the emergency room having a massive heart attack. And those gender-affirming plasties we discussed are currently sitting at the absolute epicenter of highly contested health policy, complex insurance coverage debates, and state legislation. Understanding the mechanics of the suffix isn't just a fun exercise in etymology trivia. It is a critical tool for parsing the actual real-world stakes of modern medicine.
It touches absolutely everything, from our aging joints to our emergency rooms to our courtrooms. But I want to leave you with one final provocative thought to mull over. We have traced the concept of rhinoplasty from a 2,600-year-old scalpel and skin flap technique in ancient India, all the way to modern flexible catheters that can rebuild blocked arteries from the inside without a single incision.
Right.
If the definition of surgical repair has already stretched that far to accommodate new technology, what happens tomorrow? When we inevitably reach the point where we're using targeted CRISPR gene editing or injectable microscopic nanobots or advanced stem cell therapies to completely reshape and reconstruct human tissue at the cellular level without using a single physical tool or making any incision at all, we still call it a rhinoplasty. Or will we have finally permanently outgrown the ancient Greek word for molding clay and need to invent an entirely new language for the future of human healing?